Hi, Tanya. Thanks for joining us. So I've begun the recording now. Hi, everybody. I'm Sophia Kura. I'm joined here today by Nolan D'Souza. We're going to do a quick across the board introductions, just so everybody knows who everyone is. Tanya, I've just indicated that we're going to record this session because there's going to be lots of interest in the conversation. So let's begin with Kelly. Kelly, can you just tell us your role and the role of your organization so far?
Sure. So I'm Kelly Tonner. I'm the Executive Director at the Southeast Ottawa Community Health Centre, one of 6 CHCs here in Ottawa. And we are part of our Ottawa Health Team, Equipe Santé Ottawa. And we have, as a health team, and Erin, my colleague from Ottawa Public Health, is also part of the team, we stood up a COVID community response back in an emergency COVID community response structure back in the fall, end of summer, beginning of the fall. And we have been supporting the coordinated rollout of outreach, engagement, access to testing, wraparound supports for people who are COVID positive and or high risk contacts, and now vaccinations for those disproportionately affected by COVID in our community. And Erin and I co-lead the operations kind of division of that strategy. And so I never imagined in all of my career that I'd have a closer relationship with somebody from an outside organization than my own colleagues in the CHC world. But Erin and I are pretty much joined at the hip. So we are working really, really hard right now to try and find the most effective and efficient way of vaccinating our disproportionately affected communities, at the same time respect that it takes extra work and extra effort and innovation to reach them. So that's what we're working with now.
Great, thanks, Kelly. That's a great introduction. And Erin, do you just want to briefly add to that with your role? And okay, sorry, Erin, you're on mute.
Yep, got to happen at least once a day, right? So my name's Erin Slewski. I'm a manager at Ottawa Public Health of our community operations area. And I won't repeat all the things that Kelly said, but definitely working like of late, the latest role that has been assigned to me is kind of leading our priority neighborhood vaccine efforts, and so have been working very, very closely with Kelly in the community response to be able to support that work. So I'm very happy that we're able to meet with you all today. Thanks.
Thanks, Erin. Ruben and then Tanya.
I am Ruben Rodriguez. I'm the director of the Reactivation Care Centers and the support to long-term care and congregating settings. And since last year, I am also the lead for testing and now vaccination at Humber River Hospital.
Hi, I'm Tanya Carlisle. I'm from the University Health Network. I'm the lead of our virtual connected COVID care clinic, but also got pulled into vaccination as well at the end of December. And so I do a mixture of roles, but one of the site leads, help with the planning to do the vaccinations for long-term care homes and retirement homes first, congregate settings, shelters, and now out in the community, and also do our communication materials as well.
Perfect, thanks, Tanya. Noor and Nolan, just a quick introduction.
Hi, sorry, my toddler's there. Hi, my name is Noor. I'm the project manager at Health Commons. Sorry. Can you go first?
Hi. Hi, I'm Nolan. I'm a community lead with Health Commons, providing support to lead agencies for the High Priority Community Project. And Tanya, I'm good friends with Kelly Anderson.
Oh, nice. That's great. Yeah, Kelly was on the vaccination for a bit, then got pulled up.
Okay, awesome. All right, then let's get started. Kelly, did you have a few questions you wanted to begin with, or do you want me to just, yeah, okay, perfect.
Sure. So we, in Ottawa, we have done, and we've connected with our colleagues in our sector who have done retirement homes, who have done congregate living, who have done strike teams on inpatient floors. But really what Erin and I are looking at now are how to take lessons learned from those activities and take them out into social housing. And so when we saw the tweet, Ruben, Erin showed it to me. There were pictures, and I'm like, "Ooh, that's the kind of hallway that I'm working in." So, how does that work? And you know, we've had some conversations with our clinical leads here in Ottawa, and of course, given the landscape right now, there's exceptionally heightened concern around infection control and around safety, and around ensuring that we're not exchanging speed for you know, mitigating risk and those kinds of things. And so that was the driving force between wanting to connect with you this morning. Is we already know how to do the teeing up of people and the hallway, the doors and that kind of thing. Like, we know what the outreach requirements are. The CHCs here in Ottawa are really connected with our social housing partners and our mental health and addiction partners. So we know that part. It was really just about how you set up the process and then how you managed for those extra kinds of risks in settings that are less than ideal to do vaccinations.
That's a really good question. So what we have done at Humber is to work with our Joint and Health and Safety Committee. We developed, I guess, let me rewind a little bit. So our process to do community engagement have different steps. So the first step is to recognize a building that needs basin or that is on the high priority. And what we leverage is using the Open Lab UHN information to identify. We started after we finished we did 35 nursing homes and retirement homes. And from there, we moved into the NORC buildings. So we use the data from the Open Lab to identify those buildings within our community. And what we normally do is we select the building, then we engage with the community-based programs that are already engaged in that building to find local leadership that can support the planning process. Once we identify the building and the leadership there, what we do, we call it the scout visit, and is we go to the building and we develop a leader form, and that even have a drawing spot where I can take notes. And then we assess that the hallways are wide enough, and if they are not wide enough, how can we ensure the social distancing and the safety, that there is more than one escape exit, that there is ability to secure the elevator and that sort of thing. We also, in the beginning, when we did the first one, we actually made the seniors come down to the party room, and then realized that created a lot of congestion at the elevator lobbies. And also mobility-wise, it was a little hardship. And the point was to eliminate that. So we was like, this is still not working. We came to them, but we didn't come to them far enough. So then we took it up to the hallways. So we do the visit with the partners, and then because our team is a small, like I have a team of 7. So what we do is in that engagement with the community, we also secure that on the day of the basin, there is support on the floors. So we ensure, because the nurses, we call it the model, the airplane mode. So they have a little car, like a flight attendant. They put everything on top, like a flight attendant, and then they come. Moderna for you today? Yes, but then you have it. And then at that time, we also check the consent form, and we do data entry live. And in the beginning, when we did the nursing homes, we did like downtime procedure that we will take the consent and then fill it up later on. We stopped that, and now we do data entry live. So when we go into a building and we leave, everything is done. Like, there is no worry about data or anything like that. So we secure, and what we try to do is that there is a volunteer at each end of the hallway and one by the elevator. And we also request that the partners in the community have like a list of apartments. So on the 10th floor, we're doing 1010, 1020, 1025. I don't know, I'm making this up. And then, then on the day off, we arrive usually at 9 o'clock. And then between 9 and 10, the team prepared the syringes where the basin thought. And then they prepared they draw the basin. And then we give the community partners volunteer group 15 minutes head start. So on the notice, when they engage with the community in that building, they let them know on this day, between this time and this time, this happened. Be sure that you will be on your apartment, and we will knock on your door 15 minutes before the team comes, so that they have time to put the chair out and to sit. On the scout visit, we also recognize oftentimes apartment buildings have the door in front of each other. So we determine the people on the left side will be to the right of the door, the people on the other side will be to the left of the side to ensure that people are not facing each other. So all of that is part of the scout visit, and it is taking into consideration safety, risk minimization, and stuff like that. And what we do this with this form, we then share it with a joint health and safety committee so that they have awareness that we have ensured the safety of the staff. And then when we give the 15 minutes head start, then they go door to door, put people out, and then we go up, and then we have a strategy to be able to do the building quick, is that when we have draw 60% of the doses, we go up, and then 3 team members stay behind, continue to draw, where the other part of the team start on the floors. And then at the end, one person became the runner, and the other 2 team members became another provider. So we can have up to 3 floors going at the same time. And now we're getting some physicians from the OR programs that are close coming to us. So we have done days that we have 5 floors going on. So when you're planning with the community partners about volunteers to be available on the floor, you need to do the math of how many teams you will have available to do floors, and that the volunteers match that volume. And then we do like the 5, let's say we do 10, 9, 8, and then we switch to 7, 6, and so on. And then now we have it down to a science that we can do a building of 300 people in like 3 hours or something like that. It's pretty fast now. Erin, you're on mute, so I'm not sure.
I just said that's incredible.
Yeah, and then we now have, because we identified that the airplane mode provide the most efficiency for the team, and also the most successful experience for the individual getting the vaccine itself. Because in many of the places, even here at Humber, when we initially opened our big massive space, the individual has to go check in to be sure that you have your appointment, then registration, then administration, then to observation, then to check out. It was like 6 stops before you finish your process. Now you can just sit your bum in a chair and you don't move. We move for you. Mm-hmm. And then the ability to move more people have increased. That now we also apply, we have gone now to workplace as well. We did our first engagement with Apotex in Toronto. So we did 2 of their factories, and we broke our own record on Tuesday. We did 708 people in one day in 2 different locations. We did a building in the morning and 600 people in Apotex in the afternoon by using this lineup on a corridor. And in Apotex was cool the first time that we went there, because they use all the executive area where all the administration people are, and we literally make a circle around of chairs that put 50 people, and then the team was doing like a clockwise in 3 spots, switching, and then we do it, and people were leaving and new people were coming, and we did 380 people in like 2.5 hours or something like that. It was really crazy fast.
How did you do the registration for the employer one, Ruben?
In the iPad, all done, and the employer manage the line of the people coming. And we do the same when we go to the building. We don't manage people coming. We don't manage the appointment. We leverage on the relationship that already existing community have. For example, we also have done a couple of community of faith. And please stop me, because Tanya probably have other great ideas that I want to be sure that she can share. So I'm going to say the community faith, and I'm going to give a chance to somebody else because I can talk for hours. We did a church and we did an Islamic center. And what we did is, from my experience, when I was young and very involved in the Catholic Church, I know that the church already have structures of how to communicate with their members. And out of a tweet that we put out, this lady from a church was like, well, would you come here? And I was like, well, how many people you have and what structures you have that we can make this happen? And so we have been there twice, and we have done close to 500 people in the 2 engagements that we did there. They have like a gym looking thing. It's like a basketball court. We put 45 chairs in there. On the Scout, we determined how many chairs 6 feet apart will fit in there. And the leader ladies from the church, they make all the phone calls, they make the schedule, they have someone in the parking lot to be sure that people didn't come early for their appointment. It was insane. Like, they were amazing. And I'm talking about an 81 years old lady leading this. This is not like a young person. This was an 81 years old, probably with a rotator phone in the kitchen, making all the calls. I was amazed. It was so amazing. And then we went to the Islamic Center where they do this, and they have their structure through the imam at the temple. And in there, we have done 3 engagements with 700 people.
Can I ask a question? So when you're talking about like how long it takes to do a building, or like these engagements doing, how many immunizers do you have, or how many clinical staff do you have there? 7?
Yeah.
So basically one person can do 100.
So what we do is that they do it in part of the safety, which was the original question from Kelly, is that we ensure that the team is never alone. Everybody's working in pairs. And now that we have the physicians, we are faster now because now we have the physicians, and now we go to 10 people. So what we do is one physician with one of the mobile team together. The mobile team person is in charge of the team, not the physician. And then the mobile team person does the registration and the data entry, and then he gives permission to the physician and the review of the consent, and then he gives permission to the vaccinator to go through. And then they go boom, 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 one ahead of time. So, and it has been so successful that we have decided to put more funding and strategy on the mobile than maximizing the arena. So we are now going to be creating 5 teams. And UHN have like, how many you guys have? Like 1 million? They actually, and sorry, more ideas come. Big people to relate to, politicians. They know their writing, they know how to do canvassing, they know the leaders in the community that they can leverage on to spread the news. And we have been using them a lot. And they also advocate for us to get more doses, so I like that. And also, we have leveraged on partnership with other mobile teams. We have a learning table that we meet once a week, and UHM leads it, Alexis Villa. And we meet once a week. Sorry, my French, we bitch about it, our struggles, but we also celebrate our successes. We learn from each other to see what worked for Micah Garan, what didn't work for them, and that pop-up tent that Micah Garan did and didn't go so well. We all discussed it and learned what was the good things from there, what was not the good things. And I'm going to let Tanya talk because they have like 20 teams, or I don't know how many, and they come in. And out of these relations that we created, this weekend, they're going to be on the most affected neighborhood of my catchment area. And this is because we stop competing to each other, we start collaborating with each other, which make Kelly and Erin being friends now. Tanya, your turn.
Thanks. And I think too, the one big piece of when we started is we started to work really closely with hospitals, all different hospitals right from the beginning. We just knew it wasn't something that we could all do by ourselves. So at the very start, we started with Mount Sinai, Women's College, and North York, because they all had, that was when we were doing retirement homes and long-term care homes, just to try and make sure that we could get to all of them as soon as we could. Obviously, throughout this whole piece, getting enough vaccine has been everyone's biggest challenge, I think. So it's a bit of we plan, then we stop, then we plan, then we stop. And so sometimes I think, thankfully, a lot of sites are understanding and know sometimes that we have to move super quickly because we have vaccine, or that we may have to stop and reschedule. So thankfully, everyone's been pretty understanding there. And I think too, what we've done when we were doing shelters recently, we worked with our UHN social medicine team really closely because they have those relationships in the community. We tried to also, Women's College had a lot of relationships with the shelters, and actually one of the nurses and physicians actually work with the shelters a lot. So both them and then our Parkdale Community Health Center were also the ones that led kind of our shelter piece with a site lead on our side. we really want to make sure that the biggest thing for us is having the community, so having the CHCs involved. And I'll show you some of the materials we created, but we worked with all of the CHCs to help us to create these community-led materials, and to get the input from our clinicians and anyone on the ground as well. And I think the biggest piece too is making sure that sites know we're a guest in their home. So we look to them for a lot of the pieces too. We know, as Ruben said as well, depending on the site, some you could have a room where it's a bigger room. They might have a dining room that's not used where you can do vaccination, set it up. You can have different rooms for the observation period. And I think that's the hardest part, is the space for observation in a bigger setting is what you really need the space for. Whereas the hallway, the ones that are the hallway ones, which I like Ruben's airplane explanation, and we may have to borrow that one. But we would make sure that we got people to sit out in the hallway where possible, because it's easier to do the observation then too, because having them in the rooms, you might miss someone that's not making a noise, is really quiet. So we wanted to make sure, because otherwise you'd need a lot more people from the site to be doing that observation. So we tried to do that as well. And I think too, it's having, on our side, we've started to have a site lead. They don't necessarily have to be clinical. So an on-site person that's managing when the vaccine's arriving, the people that are there, so working with the clinical groups, and we have people that are doing documentation. And so getting them all organized, and then working on the day of, we have them meet with the lead of the site themselves and just make sure everyone understands what's happening. And sometimes we'll try to have a huddle with everyone involved for the day, just so that everyone knows everyone's roles, what's happening. We also have a meeting with the sites beforehand, just a little pre-go live meeting where we go through what we would need from them, what our team would do. And that's sort of to alleviate fears, because I think too, sites are not really sure what they have to do. And they're worried about, they may have to use COVAX, or they may have to do this. So we let them know that really what their involvement is. And a lot of it's that pre-work, making sure that they can get consents where possible, knowing that on the day too, there could be consents as well. We never obviously want to turn anyone away. And so we have a list that we get them, and I can show you that, but we have a list that we get them to fill out beforehand, a checklist that gives us information about their site, a little bit of the information we need. And then we get them to start thinking about how many people may be vaccinated. And we're trying to get them to tell us if people have been vaccinated elsewhere, if people have declined, and if people are hesitant. Because the ones that are hesitant too, our clinicians can then talk to them and have those conversations. And we've been really lucky. Our physicians will sometimes take an hour to speak to someone just to answer all the questions they have, because they just want to make sure people feel listened to, understood, and want to alleviate the fear, because they know as well, especially in shelters, we've found it really hard to get people to change their minds. And so you want to have that option of just giving them the time and knowing that you're there and listening to them. I think for shelters, encampments, and drop-ins, the hardest part is just getting people to want to be vaccinated. Especially at the moment, we have so many outbreaks in shelters. So we really want to make sure that we can try and get as many people vaccinated as possible. The other thing for some of the sites is for shelters, they were doing some pre-work. So they may have either calls, or they go to the site a few days beforehand and do some of that engagement with people that are interested or have questions. And I think where possible, we've found, obviously, as Ruben said, for long-term care homes and retirement homes where you have people that are a bit more elderly, it's harder to bring them down, that obviously the floor method works. But where possible, if people can come downstairs, the other piece that helps with that and what works is other people see them being vaccinated and realize that, oh, it's not as bad as it seems. Maybe I'll get vaccinated too. So we found in shelters that really helped to change people's minds a little bit, or they'd at least feel comfortable to come and ask someone a question about it. So I definitely think a lot of it has been at the beginning with long-term care homes. It was just learning as we went and changing it. Obviously, the first few we did, we just made it up and made up the process. But we were really lucky with our clinical teams. They kind of on the ground, they have the experience, they kind of led it. And everything that we did was then learning from it. And as we went to different settings, we just tried to figure out, a lot of it is the same, but we really just tried to figure out where are the differences and where do we need to change slightly. And I think too, I'll just quickly share with you, we've got a couple of documents. So this is our checklist. So we have this is the one we created for congregate sites. So it's our dose 1 readiness checklist. And so it has information about the site, who will be accepting our vaccine shipment, just so that we can then easily just give that to our couriers, who will be meeting the vaccine team as well, so their site lead. And obviously that could change. We've obviously, in Toronto, it's sometimes hard to get parking, so we've tried to get some of that information too. Information about their homes, their layouts, if they are in outbreak, and if they have positive patients, just so we know. If they want to do that centralized or room to room, it helps us just to decide how many people may be coming on the day. And then just getting like some of the consent information off them, staffing, and then where possible, we get them to start thinking about that confirmed consent, hesitant, declined. And then the other piece is, I'll send you the link to this, but what we've done is, we have on the Michener Critical Care Learning site, we've made it now accessible to anyone, so you don't need a password to get in. But we have these documents in community-led vaccination. We also have materials for our homebound vaccinations and long-term care and retirement homes. But we've sort of split it into like the overview, training, clinical readiness, site readiness, and then one of our biggest things is the vaccine distrust and building confidence. And we've just pulled links. So we haven't created anything, but we've really just pulled what communities have created and then categorized it into either communities. We've got, say, the Asian community, the Black community. We may have millennials or different groups, so that it's then fit for whoever needs that information. And you'll see too, this is our site readiness and walkthrough checklist. So we've just tried to make it really simple for people. We've tried to give them the links where possible, what they would know for the day of, what the roles and responsibilities of the teams are. The clinical readiness walkthrough checklist, we've given them information on what you should be bringing where possible. The clinical vaccine team roles and what they will need to do. So we've started to try and give them a bit some more description on what those roles will do there. The clinical setup, what they do the day of, the vaccine readiness, that kind of information. And then also we have some clinical training. So our teams very kindly pulled together some videos as they were going, like how to draw Moderna and get the most doses out of the vial, what they'll do pre-day of, and all of those pieces. So with the videos, it's say confirming the vials, the options, preparing your mobile vaccination cart. So getting all of those pieces done. I think and it's more so something that they can look at the very start. They may not need to look at it again after, but we're now also trying to create a checklist as we bring on new site leads, the on-site site leads. We're trying to create a checklist for them with some key contact information. So if the vaccine doesn't arrive, then here's what you need to do. Here's who you call. If we've got a no dose waste plan, so if we're making sure that there's never any doses that are wasted when we go on site. It's obviously really hard to be exact because you never know how much you're going to draw from the vaccine. You never know how much you're going to, people may consent, but then may not show up. So we work with a group of different groups. And so it may be other sites that people were missed that may come to the other site. We have healthcare workers that were unable to get into a clinic. So we do that. And so we have like a few kind of people that we check with. And we continually try to update that list to make sure that we have those contacts for people. So that's kind of it in a nutshell. But I think really the biggest piece is obviously for our documentation, that working with the communities was really key. And as we start to go out to those postal codes, we really need their involvement and want to make sure they know that and have them involved and have the right people there. I think as Ruben said, you want to have the people that those communities know and they feel comfortable around, especially the ones that we know there's going to be a lot of hesitancy. We're trying to make sure that even the clinicians that are vaccinating may be a part of that community or that people feel comfortable going to. And so we're trying where we can to do any education beforehand, then have those people on the day of. We will probably have more clinicians there just to answer questions. And I think that's what we learned in shelters is we have additional clinicians that are not even vaccinating. They're just there to talk to people.
Mhm.
And so those are some of the things, depending on the site, where we start to see the differences.
That's great, Tanya. We've been sharing out the content that you have been creating, but I really think that the narrative along with it, yours and Ruben's description of what it looks like in the building is really helps to ground the whole toolkit in a meaningful way. So I think we will want to share this recording and as many insights as we can, maybe snippets of your descriptions alongside the content. One of the things that the lab has been doing with the partners, so the province names 16 high priority communities that are responsible for some of the areas with the highest rates of transmission. So Kelly and Aaron, for example, are the leads in Ottawa. And in each of those communities, there's a local community lead. So we've been working with those community leads to say, when mobile vaccinations come to your community, have you identified locations where you can have either door-to-door or smaller clinics that are depending on the population most appropriate? And have you already identified which populations from your community are likely to access that site, who your partners are in the neighborhoods that you can reach out to do outreach, to be on site that day? So that planning is happening. And I think one of the key pieces is connecting that community side of the house that's really leading the groundwork to get everybody prepared with the work that you're doing to lead on the acute care or the sort of mobile team vaccination strategy. So I think bringing the two sides of the house together is going to be really important. The other thing that I will say is that we're really working hard to make sure that there's good shared knowledge transfer, because once you leave, these communities will remain in place and continue to do vaccinations probably for a long time. And so we really want them to learn as much as they can from you, from an infection prevention control standpoint to logistics to a sustained kind of maintenance of a clinic. So this is really, really helpful. And I think just knowing that that whole community infrastructure side is also there for you to tap into, I think is critical. Kelly and Aaron, you had a question about second doses. Kelly, did your question about observation get answered?
So there were kind of two parts: is what's on the cart on the airplane for adverse events, or do you have a separate cart that has your epi and all that kind of stuff?
So on our cart, and I will let Tanya also share. And our cart on the top have the sharp container. On the side, we have the garbage. And then we have kidney beans with the alcohol swabs and the Band-Aids. And we actually prepared the Band-Aids before we go up so that it's just grab and put rather than having to open the thing. We have a hand sanitizer, and then we have a kidney bean that we put the syringes in, and the runner bring the supplies when the cart is running out. And then we have in every cart there is an EpiPen. And then the nurses bring their own stethoscope in case of the individual start having an anaphylactic, just to check the chest. And that's what we put on top of the cart. And then we call 911. We do not bring oxygen with us. It's a 911 call. And
we do something similar.
No reactions so far.
Oh, nice. We actually last week had 2 reactions, from like having none to one day we had 2, but they were, one of them was, and one was a minor issue, someone fainted. And then one was, I think that was more an anxiety related, but then one was issues breathing. I think it was a bit of a reaction to the vaccine itself. So we let the sites know in advance to call. They will be the ones that are responsible for calling 911 because they know the area, they know where to send them. It just makes more sense in that way. But our clinicians will be the ones that treat the person until the ambulance arrives. So we try to have the teams have an anaphylaxis kit where possible, but it's true, as Ruben said, it's really the EpiPen that is the most important piece. And then I think too, we're going to just add, this morning, one of the site leads asked if we could add a thermometer, blood pressure cuff, and a to that as well, just for the patients, I think, because there is a bit more, some people have a bit more of the anxiety, and just to make sure and to check that there's nothing else happening before if needed. So it's more there as a backup.
And then
Sorry,
just-
I didn't consider fainting an adverse reaction. I considered a drama. And then we did have one of those ones at the Apotex. The lady was pale even before we arrived to her chair.
Yeah. And then, sorry, last question. Doing the hallway and doing the airplane mode. You obviously start at one end, everybody's in the hallway. So, you know, you have somebody observing and watching as the clinicians go down.
So
And
that's part of what we use the volunteers on the community partners for, because we move in one direction, they are behind, and we actually encourage them to chit chat with them. And most of the facilities, what we ended up doing is we bring the little yellow sticky notes and we put the time in there when they can go back into the room. So we put it at the door so they know when they can enter back into the apartment, because sometimes it's hard for them to remember. So we put it in there as a cue.
And so does the clinician team stay on the floor until that last 15-minute period has ended with the last vaccinated client? That's what I thought. Okay.
And sometimes the community partners are clinicians themselves. So if that's the case, we leave one of them there. And then the first thing that we do is share the number of one member of the team that would be in each floor, so that if one clinician from them stayed, we will always be one floor below that, is run to the stair, go up, stick the needle and call 911.
Yeah, and the same for us. I think it's we've done it too, that for those that we normally have, I forgot to mention, but we generally have 2 people that document for one clinician on the floor to floor model, so that they can kind of just keep on moving forward, because the documentation, it really takes a lot longer than the actual vaccination itself. So they'll go ahead, they'll talk to people, put them in. We try to do it with the sites so that the sites do some of that pre-documentation beforehand. So they'll give us information to, we do a bulk upload in COVAX where we can the day before, especially when we've got, say, 50 plus people at a site. So then they're not having to do it for each person. So we'll get the site to actually give us, I think the mandatory pieces for COVAX, first name, last name, date of birth, and gender. The OHIP card is on there as a red flag on the form, but it's not mandatory. So you don't have to have an OHIP card to be vaccinated. So we try to at least get them to do that. So then that way the patient is in there. Obviously, we'll add any additional people as we go. But then that way they'll do the pre-check-in for the patient. The physician will then re-ask them the questions about consent when they vaccinate. And then they'll do a checkout. And then the next person who's helping with that physician will then do the next person. So they kind of move along that way.
Sorry, Tanya, before I forget, because you mentioned something important. What the health card does help with is, now that the data set in COVAX have every single individual in Ontario with a health card, you enter it, look up the person, and all the data is their address, name, last name, so that you don't have to do full manual registration. So that saves a lot of time. Sorry, Tanya.
Oh, no worries, no worries. And I think too, it is very helpful as well, even for checking, because there's a lot of people that have similar names, even date of birth. So you want to make sure you're not doing that. We've just found that there's a lot of people that either their OHIP card has expired, they don't have an OHIP card, they might be undocumented. So we obviously want to make sure that they still get vaccinated.
And to that point, Tanya, we did have something interesting happen to us on Wednesday. We got a call from Peel Region, because in COVAX you also put like the name of your staff and whatnot. So a nurse in Peel Region have a person with the same name, last name, and birthday of someone that we have done the day before. And she called us to be sure that the consent was not the same person, because she was afraid to give the next day a different brand to the person. And I was like, this is brilliant. And so lots of similar last name, but for us, these persons, that neither of them have OHIP card, but they both have the same name, last name, and date of birth, which was kind of coincidental. And what was funny is the one person have 2 names, and that's how we determined there were 2 different people. That was
nice.
Wow.
We kind of put postal code in too where possible. especially for people that don't have an OHIP number. So then at least
Oh, I guess the nurse didn't thought about that. I mean, the addresses were there, but she didn't thought about it. The other thing is, we noticing more and more as more people get vaccinated that it is very important to do the data entry live, because you might find people, and we did have an incident on a nursing home of an individual that transferred from another facility who already got their 2 shots of Pfizer, and that nursing home was using the downtime procedure that they complete the consent form, and then we do the data entry. And then when we did the data entry, the guy got Moderna. So these men have now 2 sets of Pfizer and 2 sets of Moderna. So he's probably the most protected individual in the province. So
Can I-
important to check the data in advance.
Yeah.
So I just have a question about second doses. So I know locally, you know, I've been trying to understand like how we could potentially do this, and so what I understand about the provincial booking tool is that you can upload kind of like hidden clinics where then you can kind of go in behind and enter people such that they would then get the second dose. Is that something that is the consideration of second dose? And maybe I'm newer to this, so just kind of getting a hold of the details. So maybe I've said these things a little bit wrong, but yeah.
No, I get your point. So for the arena or sit down clinic, we do follow the second dose appointment, and when the individual leave, they know when they're coming back. For the mobile teams, we have a very ultra sophisticated system where in the calendar, when I do an event, I already book the next day to come back to the same place at the same time. Very sophisticated, like top of the line, my pen and my paper, and it's killing it.
Yeah, and I think it's the same for us where we, I think what the hope is, there's some sites where they can have the second dose because they're on that priority list. So we obviously make sure that we're doing those within the time frame that we can. So the 4 weeks or 3 weeks, depending on if it's Pfizer or Moderna. Then anyone else, we're just letting them know that it'll be approximately 4 months. We're waiting to see, we tell everyone too that could change, because as with everything to do with vaccinations, it could change. So we're not necessarily giving out dates. We would say to them that it will be within the 4 months. But we just know that at any point, anything could be different. And I think the one thing to add is for people that are getting vaccinated, we've been finding when we're going to sites, because there are some people that say they've been vaccinated, but they don't have anything they've got their first dose, but they don't have anything in the system, or they haven't, but we were told that they had. So we make sure we leave that onto the site themselves, and the site leads to confirm it if they're not in the system. Because there are times where they might not have been put in, they might have been in error, but they did get vaccinated. So we're not going to necessarily trust people. I mean, at some of the sites, you've got people that have cognitive issues as well. So you're not necessarily, you want to make sure that the site takes that responsibility where possible as well.
Tanya, does that mean that you err on the side of giving them a shot and asking the site lead to confirm documentation, or no, you wait?
No, we wouldn't give them the shot necessarily. We do try in advance, especially for going back to a site for a second dose. What we do is we'll pull the list from COVAX, get the site to actually make sure that they'll get everyone to reconsent, because you don't have to fill out the consent again. You just have to look again at the criteria, make sure that they're able to get vaccinated. But they'll confirm with everyone that they want the second dose. Some people will refuse the second dose because they might have had a reaction or they don't want it anymore. So they'll make sure, but they'll also they may add additional people. So then we confirm with them, well, are these people actually truly, do they need it? They went on the list. Did they get their first dose? So we'll do that comparison with them. But we will just make sure, because the other piece is that someone might have gotten Pfizer, but we're doing Moderna. So we just want to make sure that we're not doing any of those crossovers.
Great. That's really helpful. Are there any other questions for the team? I guess one question that I have is whether or not, Ruben, do you lay out a kind of a calendar that you can share with local community partners, so you can sort of establish what the building addresses are and then just send it out to anybody that's local to manage all the outreach pieces?
So we really leveraging on the relationship with our Ontario Health team. So here at Northwestern Toronto, We have 5 key players, the hospital, and then the Black Creek Community Service, Luma Care, Loft, and Unison.
Yeah.
And then what we have done some buildings also with Toronto
Community housing. Toronto Community Housing.
Thank you. I couldn't say that. TCHC.
Yeah.
And funny enough, our lowest success in organizing have been with Toronto Community Housing Service. And I don't think they understand clinical piece, and it's hard for them to understand. But what every single housing building have community providers like Luma Care, Unison. So we usually put one of them. Oh, I like that new member. Hi.
Say hi.
So we use our relationship with them, and we usually put one of them as a lead. For example, the 2 buildings that we're doing today, and I have to go there in a little bit. We have Loft took the lead on this one. So the Loft individual, she did the preparation, they did the canvassing, they did the support of the residents to complete the consent, and they will be the observers or the volunteers on the floor as the team is going through. And then next week we're doing one of the most affected FSAs in Toronto, which is M3N. That we're doing a lot of work there with UHN. But on Tuesday, we're going to these buildings there called San Romano Way. And we did those ones with Black Creek Community Service. And they have been there for 8 days, canvassing every day and taking notes, and they put a pop-up table and stuff like that. For testing, we did a lot of wrap-up service with the same community partners. So we leverage what we learned from testing to translate it into the basin. It's just a little bit harder to do wrap-up service on the basin because it's a little more complex, and I don't know, when you're doing the testing, there is a less volume oftentimes when you do these pop-ups, but when you do the basin, there is more people, so it's hard to organize like food for everybody and stuff like that. But what the community service people do is that they usually leave the individuals with a little flyer of how they can contact for service and stuff like that, and that have worked for us. We have learned now that we're moving into, and maybe something to consider when you are in Ottawa, going into the more the low-income neighborhoods. A lot of people are afraid to get the vaccine and be sick and not being able to go to work and not get paid, or the times that we're coming is when they are at work and they cannot be there. So next week in San Romano Way, we're doing something cool with UHN. So we will be doing the building between 10 and 4, and UHN will open a theater. There is a theater in the complex. So they will be on a standalone clinic downstairs. So anyone that came from work that we didn't catch on their apartment can go to the theater after, but also anybody around there that passed by, yo, we have basin here, come and get it.
Yeah, because I think it's a hard piece too. There's a lot of those places that we try to work with the sites too, to just understand if you've got a lot of people in the building that can't make it until a certain time, there's no point to be doing it in your normal like 9 to 4 or 9 to 5. And I think too, the same thing that Ruben said too, we really work closely with the OHTs on the list, but knowing as well that sometimes not everyone is on a list either. I think especially what we've found with shelters is that there were shelters that popped up because obviously when you've got limited, you can only have certain number of people in a space. Then they had like sub-sites pop up, but no one had that on a list. And so we've started to like add to lists too. And then they share them back with the different groups that they're working with. Where possible, we do try to organize clinics in advance, but it's just been really hard. Like that was our hope at the very beginning. Maybe we were naive to think that, oh, we'll just do a few and then we'll be able to plan months in advance. But I think it really it's just generally maybe a week in advance, maybe a week or 2 if we're lucky. But I think too, the other thing that we're finding is especially there might not be as much uptake at a site, so they just might need another week to have more discussions with people. Some sites want to do it sooner, and some may want that extra time. And then also some may be on outbreak, and so then it may be too that we can't actually go in, depending on if it's a lot of people that are COVID positive. we do go into sites that are in outbreak where they're COVID negative, but they're isolating, they have no symptoms, they can be vaccinated. And our team obviously is very careful to be wearing all their PPE, making sure they're following the protocols, and they do those people last. So they will then change their gear and then go and do that, take it off, change it again. So we will do those as well. But I really think it's our biggest barrier has been vaccine at the moment.
Erin, you have your hand up.
Yeah, I just have a question. So I was thinking when Ruben was speaking just around like the theater, or sorry, I'm not sure between Tanya and Ruben, but like the theater set up kind of in below. Do you have a process for kind of a walk-up kind of system, like maybe giving bracelets or something?
Yeah, so we're actually doing that this weekend. We're having, as Ruben mentioned in the community, we're going to be going to some like being more set up near some key buildings that we have identified in a high risk area that are more high risk. So we'll be giving people out, Michael Garin actually did this, so we're borrowing their idea, but we're gonna give people out numbers. So if we have 1,000 vaccines, we'll have 1,000 cards that we give to people with the day and date on it. And then once we run out of that, they'll know that they're on a list, and we'll probably, I think they're numbering them. And then once we run out, then that's all we have for the day. And we'll let people know that we're having additional clinics. So we're going to test that and I guess see how it goes.
I would love to hear how it goes.
But I know Michael Garin, I think that really they were successful in that way, because then you don't have everyone waiting around as well. Because if you've got 1,000 doses, you don't want 1,000 people in a small area. So they may give them numbers and then say, come back in an hour or come back at this time. But those people are then guaranteed a vaccine.
There has been lots of conversations about how to manage crowds and how to think through, the smaller clinics, if you're setting them up. I think in Toronto, public health seems to have access to a little bit more supply, because we're doing some clinics next week in Rexdale, and they're planning for 200. And we said, what if 500 shows up? And they were like, we just call one of our other sites and get it that day. And I was like, wow, that is not the flexibility that the hospitals have. So there's some flexibility more on the public health side, at least here in Toronto, to be able to harvest vaccine from other places. But we're still planning through, what do you do if a lot more people show up than the vaccine that you have available? And part of the ways that we've been thinking through how to manage that, because we're also anticipating people will come from other areas. And so on the flyers, we're going to say we're checking ID for the postal code. We won't be checking at the site. Actually, we don't want to turn anybody away, but just to preempt, I think the arrival of people from other postal codes will be saying that we will be. And our intention is to actually advertise quite locally using partners on the ground, just to get the word out by word of mouth. But I really like the numbers idea. And Nolan, if you can bring that to the Rexdale team, I think that's a great way to manage it. So those are all really good strategies. And one last question that I have for Tanya and Ruben is whether or not it might be possible to attend. You said you have weekly meetings across the teams, Michael Garin, Humber, UHN. If one of us can attend and just take notes, because I think these strategies will start to come up. And then we can push it out to the community partners in Windsor and Ottawa and in Peel, who are working pretty closely with to roll out similar strategies.
Sophia, you know Alexis Villa, you have been in meetings with her before. So she is the chair of the group. Great. So just connect with her, and I don't think it will be a problem.
No.
Okay, awesome.
You're definitely welcome to join the meeting.
It's just we've learned a ton today. It is so amazing and impressive what you guys are rolling out. And I think the learning and the innovation that you are sort of doing in real time is just incredible.
Sorry, Sophia, I did remember something. I keep talking about the community partners, but remember, buildings have superintendents. Don't forget them. They know everyone.
Yes.
Yeah, we use them too to do a lot of the outreach, and depending on a site, so we'll know we sort of try to find out from whatever groups know the areas. We'll try to find out if there is a good superintendent. We'll make sure that they're helping us to talk to people to get that information out there. If we know that there's one that it's maybe not as good, we might get more people to go to that site to do some of the pre-work. So yeah, it's definitely depending on, we use people in the community, well, not use, that's the wrong word. We work with people in the community to make sure that when we're going to the buildings, everyone has that equal opportunity. I would say too, one thing about the crowds, and that's what we were trying to figure out the other day when we go to the postal codes, because we know there might be 25,000 people in that area. We don't want everyone showing up, and we're trying really hard not to have necessarily security there or police there. We don't want, I know that that may turn some people away. So that's why we're trying this more so. It's still a pop-up clinic, but it's in an area with multiple buildings. And then we'll try to sort of have multiple groups in different ways. So we're trying to figure out that way so that we're not having too many people turn up and not having to turn people away if we only have so much vaccine.
Thank you guys so much.
And sorry, also remember the owners of the building.
Yes. Yeah.
Yeah, or
Have you
property managers, yeah.
Have you found it difficult to find those people, the owners and the property managers? Did you get the list from the city?
So we got the list from the Open Lab at UHN of the
Yes,
buildings.
Yeah.
And then usually the template from UHN, from the Open Lab, it actually says what community partners are in there, and then we just know who to find. The politicians who I mentioned earlier, for us, we have one of our MP from the NDP. He is lead for constituents engagement.
Yes.
She knows everything.
Yes.
And she said, that building, oh, that's Laura.
Yes.
I have her number. Here you go. Oh, that's with Felix. I know Felix. I will take care of that building. You don't need to worry about it. So leveraging those people, they know everything.
Yes, absolutely. Just from electoral campaigns, right? Like every party has a detailed list. The councillors will, the MPPs and the MPP's offices will have constituency lists, and they're very accustomed to breaking up a map and figuring out how to canvass, for example. So we've thought about opportunities to kind of leverage that. That's great.
Yeah, and I think the one last piece is I forgot to mention is that when we go out, we're getting new teams going. We try to get them to do a shadowing, because really they're the learning that's helpful. And even if it's just one of the main clinicians that can do it, and then they'll go out and then they can teach others. And so that's been really helpful too. So if you ever have anyone that is here and wants to do a shadowing, or we could always have one of our leads from the family health team. She's always, I'm sure she'd be more than happy to talk to someone if you want someone to walk you through what they did on the ground from a clinical perspective.
That's fantastic, Tanya. I think we'll take you up on that. I'm just going to stop the recording now. Thanks everybody, but don't hang up.